right. Hi, everybody, and welcome to today's episode of Oncology Data Advisor in honor of National Minority Mental Health Awareness Month. I'm joined today by a few of our Fellows Forum and Editorial Board members, Megan Claire Chase, Alankrita Taneja, Samuel Kareff, and Waqas Haque, who will be sharing their perspectives on this topic. Thank you all so much for coming on today.
So, hello. Yes, I'm Megan Claire Chase, but I'm also known in cancer land as Warrior Megsy, and I'm an 8-year stage 2A invasive lobular breast cancer survivor, patient advocate, and I also changed my career to work in this space. And so, National Minority Mental Health Month means a lot because I experienced so many barriers of consistently being dismissed. My breast cancer symptoms, they were different. No one really identified them as, something was wrong. I was consistently like gaslit and told, you just need to lose weight and eat better. And I'm like, okay, the whole point is I'm gaining weight. I've got this weird bruising. My hair started falling out only on the left side. Eventually, I actually got that cancer diagnosis, I really felt validated because I did all the right things. I advocated for myself. I felt very lucky that I come from a family where my maternal grandmother, she's a registered nurse, and she told our whole family it's your patient right to change doctors, it's your patient right to ask questions, and it's your patient right to get pushy if needed, right? And so it was literally over 2.5 years. I'm going back and forth, and it wasn't until I felt my tumor, it was palpable, is when everyone took me seriously. And what that did to me mentally of being ignored over and over again. Then I enter another underrepresented category, aside from being Black, and then a woman, then a Black woman in the South. And then I was diagnosed under 40 and being called a young adult every 5 seconds, and then not even seeing anyone who looked like me in the infusion room, who looked like me age-wise as well. The doctors who looked like me, where are they? And that really has taken a toll, and even in my survivorship continues to take a toll on my mental health of dealing with PTSD, anxiety, and depression. And so I'll just kind of leave it there and let everyone else chime in.
Yeah, I'm happy to kind of follow up, and I wanted to really thank you for sharing your story so courageously. It's a really difficult disease, invasive lobular cancer. It's significantly less common than invasive ductal carcinoma, which is what a lot of folks are more used to. Hearing your experiences, I'm reflecting on a lot of my patients that I've served as well, and I see so many of those disparities that you've kind of shed light on. And I just really appreciate you kind of serving as a patient advocate for others so that they don't have to go through what you did. So thank you for that. I wanted to follow up from a couple of the themes you just left us with at the end of your story, and those are related to things like PTSD and anxiety. I think this is a really important session we're having today, and even though we're in collaboration with National Minority Mental Health Awareness Month, there are a lot of overlapping themes with cancer care that we're kind of focused on here with Oncology Data Advisor. I wanted to share a little bit of data from our Human Rights Clinic of Miami that I collaborated with during my time as a medical student at the University of Miami in the mid to the last decade. And essentially, in short, this Human Rights Clinic is a clinic that's designed to assist asylum seekers and refugees in their kind of hopes for establishing permanent residency here in the United States. So what we do is we help corroborate some of the claims that these folks have when they're working with the immigration system as it relates to both physical and emotional traumas and abuses that they suffered and whatever medical and psychological sequelae they are. So when we actually analyzed our data over 5 to 6 years of operations in the mid to last decade, as I mentioned, we saw some really alarming rates. When we screened folks for PTSD and major depressive disorder, we actually saw rates of over 2/3 positive for PTSD and over half for major depressive disorder. Now, we can contextualize these findings with South Florida at large, where we are outside here in Miami, and those rates are lower than 1/4 and 20%, or internationally, where they're maybe in the single digits, depending on which cohort you're looking at. So clearly, there's a lot going on with this minoritized population. We really need to kind of keep a heavy focus on these folks as they're kind of entering and integrating into our society, noting that there are a lot of legal and other barriers that they pass. So as I'm thinking about a lot of populations that we might call minoritized, it's so important that we really focus on their mental health moving forward.
Absolutely, Sam, and thank you so much for sharing, Megan and Sam. I, going to be specializing in the field of multiple myeloma, going to be working in Philadelphia, with, predominant minority population in the hospital, and time and again, studies showing the disparities in outcomes, in patients with multiple myeloma who belong to the African American community versus other races, especially Caucasian. And there was also a very big study that showed that when same treatment was given to people with multiple myeloma who belong to Caucasian race as opposed to the African American race, the outcomes were still different. So it seems that there is a component of probably structural racism, bias, that is playing a role in outcomes, which is beyond comprehension by, doctors and science. For example, in multiple myeloma, there was a large survey that, studied over 3 years, interviewing patients who worked in healthcare and asking them about how their experiences were, and 60% Black adults, half of American Indian and Alaskan natives, and 51% Hispanics, 42% Asians said that they prepared for possible insults from providers or staff and felt that they should be careful about their appearance to be treated fairly during healthcare visits, at least some of the time, as compared to 33% white adults who had the same observation. So, Megan, being a patient, do you concur with these results, and what is your opinion about, what research has found?
I mean, yes. And I have learned over the years, and it's actually something in my community that we all kind of inherently know that we do. And I have done it dressed up for my appointments. Even though I am sick, I have to make sure I watch my tone. I need to make sure that I'm making them comfortable so I know they'll listen to me when all I really want to do is like scream and shout, like, I don't feel well, just help me. And all of that pressure and all of that anxiety and like anger is all wrapped up in our bodies. And I truly feel that that's what also keeps us away from the doctors, because when you're consistently, talked down to in a condescending way, when you're not believed, when your symptoms are not believed, it makes it harder for a person of color or from another minoritized community, as I always want to include the LGBTQIA plus community as well, that we don't want to go back to the doctor. And that's why we're diagnosed at later stages, and it's really infuriating. We really need that cultural competency, but not just once, but like ongoing, because what that does to our mental health, we've taken time off from work. And then once we get there, oh, we don't know, or you should just go, the general type of explanation when something is wrong, what that does to you, and that stress that we continuously carry. So I totally agree with those findings.
Yeah, thanks for sharing all that, making clear all the sort of things so far today. I think for me as a fellow, I think so much of the patient visits, so much on focused on making an assessment of the patient, what's the performance status, and then the view of systems is so much focused on physical symptoms that people are facing. But often you don't really get time to really talk about someone's mood, how they really do sort of be feeling on the inside, things like that, right? Just sort of going back to the biopsychosocial model of medicine, and actually had the opportunity to go to a patient advocacy conference and kind of hear from like different patient panels, for like patients with sickle cell or multiple myeloma, things like that. And it's just really powerful to sort of hear people's other perspectives, even if you can't actually feel it yourself, just to at least know what they're going through. So sort of about my own involvement in sort of minority mental health has been with creating patient visitation programs for patients who are admitted to hospitals, and just sort of making sure that someone's there to at least like a chaplain or someone to do a visit. And I started this program across several hospitals in the country, and actually did some reviews of Muslim patients who are admitted to hospitals in the United States. And one thing that we found was that a lot of the tools that are used to validate spiritual health and spiritual assessments in this patient group are often, they're actually like validated in groups other than Muslim patients. So oftentimes when we think about minority health and the scales that we get, like want to use to address their mental health, we should try to create scales that are based on the actual population themselves. So we actually hear from their own perspective.
You know, I might add, just because this topic is crucially important when we're talking about either validation of tools or even data collection in the earlier stages. There's a huge call right now from organizations like ASCO and others that are really trying to ensure that data that we collect in terms of either race, ethnicity, ancestry, socioeconomic status, et cetera, are really desegregated. And what that means is basically not putting blanket statements on kind of groups, whether those are genotypic, phenotypic, whatever they may be, but making sure that patients and their communities are really represented as best as possible. So I think that's one example of that push that we're seeing right now in medicine and how crucially important it is to translating into practice in real life.
You know, what I would say to that is there needs to be a better job of showing patients from these communities that you're trustworthy. We constantly talk about that trust, but it's also like we definitely want to be included in the research. We need to be included in the research, but what is being done to explain to our communities, hey, this is what we're doing. This is why you should trust that it is safe. We were going to be safe with your data and how you're helping science, how you're helping others that will look like you in the future to make sure that they will be able to get treatments that work for their bodies. And so I think that's what's missing, because we can talk in circles all day of, yeah, we need this, but what are organizations and cancer centers and researchers doing to show communities like mine that you are trustworthy and that you're meeting us and letting us know, hey, we see this gap in care. We want to talk with you, not to you or at you.
That's a great point, Megan. I think time and again we talk a lot about disparities in enrollment in clinical trials, and we really don't know how to fix that gap, like you said. And some of the research out there says that people who belong to a minority group are more likely to feel more comfortable with physicians from a minority group or staff from a minority group that can explain the trial or drugs to them. Would you agree with that? Do you think that is something that we can incorporate going forward?
I mean, 100. And again, it's that anxiety and that frustration. And it's also like a sadness, because a lot of times I don't think people truly realize that a lot of these atrocities that have happened in the cancer space and the research space, it wasn't that long ago. Like certain communities, we still reference, like in my Black community, we still reference Henrietta Lacks and Tuskegee, and then in the Latin and Hispanic community, still mentioning the sterilization of Latinas, and like it wasn't that long ago. And I think if we can start to do that and feel like, wait, you really are listening to us because you're acknowledging the not so distant past, I think could help a lot in making us feel more comfortable. But also too, if we keep waiting for more physicians and researchers of color before we go to the doctor, then that's not going to help anyone. So what can we do now, where we are now, and really making sure that they're acknowledging, saying, hey, I know we come from different cultures, but I'm here. I want to listen to you, because I'm so tired of hearing, oh, this doctor is brilliant, but they have a terrible bedside manner. Well, you know what? You need to improve that bedside manner, because that everything you say, we're taking that in, and that really affects us mentally and emotionally and physically.
I think you both highlight really important themes on both the patient and provider relationship, right? And what really just boggles my mind is that this is not only kind of the right thing to do, but also it leads to health outcomes that improved. We just saw a huge JAMA study last year that showed that providers identifying as women, when they served patients identifying as women, had better health outcomes. I mean, this is massive. The news talked about it a lot and it's kind of faded away, but as a thought experiment, should women be allowed to prefer women providers? It says that they're going to live better if they do. These are things that we have to ask ourselves both at the individual and the societal level moving forward.
That
And
is
I
so
can
true.
also,
Yeah, I was just gonna be like, yes, clap, clap, clap. And I wanted to ask, especially as I think about like, the Muslim community, and there are other communities where they need to see a female doctor, like, or, a gender specified type of doctor. And what are we doing to make sure that we're meeting those needs? Because I think to myself, I'd be scared to death. And, religion was like, I can only see a female doctor, and how just the anxiety would go through the roof of like, I can't see you, so therefore I'm not going to take care of my health because this doesn't fit what my culture needs me to do and say. So, yeah.
Yeah, definitely. And I think also just to expand beyond that, it's not, only patients that need accommodation sometimes. It can also be providers and also other employees in the hospital space, whether that be in terms of, meal accommodations, having access to a certain kind of prayer space, or even other kinds of accommodations. So it's very important on multiple fronts in the healthcare system.
so, I'd like to bring up a new sort of topic about advocacy groups and, meetups amongst people from the minority groups, with cancer. So, Megan, do you think that, participation in these groups and timely talks by providers where, two-way interaction can happen and concerns can be shared would be helpful to improve the, rates of anxiety, for instance, and to inculcate the sense of belongingness in the community?
Yes. The short answer is yes. Because when they're talking together, it humanizes the medical community, because they're human, we're human, but also just acknowledging those differences, but also reading those nonverbal cues. And so I work for a national nonprofit, and something I like to do is try and make it as conversational as I can when I'm putting programs together, or when I'm interviewing for podcast episodes, etc., to let them know that it's not just about listening to what we're saying. It's also taking that time to read the nonverbal cues as well. And I think advocacy groups and things like this, what we're doing right now, really helps um, others know that we hear what you're saying, and we know that there's still so much to be done, but also acknowledging like what has been done thus far, which is still a lot. And I still don't think that message gets out enough, but it does help. With advocacy groups, we can help get that information out as well, to say, hey, we've talked to, this people at this cancer center or this researcher here, and like they're trustworthy because a lot of the patients are looking to advocacy organizations and patient advocates like me to say, you know what, is that a good person? Is that a good place to go? Yes, because they will listen to you. And so I think we can never negate how important it is to continue to have ongoing trust and ongoing partnerships and collaborations with advocacy groups and patient advocates of color.
How do you feel about interaction in places such as churches, where we can reach the community, and since there is a bigger gap in communication or in expressing concerns, where when you go to a provider, you might not have the time, for instance, or you might not just that time might not be enough to develop that trust. So do you think that providers could actually do outreach in places where minority groups can gather, things like that? Do you think that would help?
I'll say this, and then I'd love for everyone else to jump in. I just want to say, meet me in the middle, like meet us in the middle. Yes, it's so important to like show your face in the different community settings, such as churches or like community centers. And I think there's a systemic issue going on though, because a lot of the doctors, like there's no time to like really build that kind of rapport. So it's super important to understand the community that you're in, but also go to communities that you are not familiar with to learn and hear them. Let them see you, talk to the community leaders and set up something so you can just have a talk with them, but ideally bring someone else of color or that community leader with you so they will believe what you're saying and that you're being authentic. And so I think that is huge, but it's just so important that we shouldn't always have to keep coming to the doctors and the cancer centers and the researchers. Like, come to us to show us that you want us and you want to make sure that we are staying on top of our screenings and having medical adherence and really listening to us. So there's so much that could be done, but meet us there.
I love the message about meeting in the middle. Taking some inspiration from our cardiology colleagues, there's actually this pretty cool trial a few years ago called the barbershop trial. It was where pharmacists actually teamed up with barbers just to promote blood pressure checks and things like that within the barbershop, and it was actually shown to improve blood pressure readings among Black males in that study. So just really creative examples of how far we can go with this.
It's amazing.
Yeah. I really appreciate the call to action, Megan Clare, that you're leaving us with. And I want to echo it and remind really busy providers without a lot of time that this shouldn't even just be looked at as an investment, which is a really great one, by the way. You really take the time to understand your patients and the communities they come from, but just looking at it as the right thing to do, right? And it's not even up to you to kind of Google where community screening fairs are and that sort of thing. Just talk to your employer. They're intrinsically involved with the communities that they serve because these are the patient populations that they want to work with. And you can just jump on board to things like that. It's not hard. It takes a few minutes and it's overwhelmingly worth it, in my opinion.
The Leukemia and Lymphoma Society, LS, provides grants for things like that as well. So there's, opportunity to get compensated for your time. If, I know our providers are really busy and patient care itself, takes a lot of our priority in the clinic.
And, and again, in talking about that mental health aspect, that's why I say those nonverbal cues are also so important, because even if you are comfortable with your medical provider, or if you're part of a clinical trial or something, sometimes you just get embarrassed or you don't really quite know what to say. And so another way of keeping those communication lines open, but also, not everyone is vocal like me. I'm pretty darn vocal, but you put me in that hospital gown, I'm going in for my scans. I'm very vulnerable. I'm in a very vulnerable position. And a lot of times a medical community doesn't realize it works both ways, where we're watching you. Are you giving us eye contact? Are you actually saying hello? Or are you being condescending and saying, well, do you know why you're here today? Yeah, I made the appointment. This is why I'm here. You know what I mean? It's those small things. And more importantly, it's about being like, okay, I'm not comfortable with talking with this person, but you know what? I really like that nurse. I liked your nurse. Would you mind having that nurse come in again? I just had something else I want to go over with her, because if you're scared to talk to that doctor, then whoever you did feel comfortable with, that's who you could communicate with. And that takes so much of the stress off of feeling like you have to know everything, every question to say in the moment, and you don't. And I think that's just a lot of pressure that some of us feel in the community when we already feel like we're not being heard. And then if we can't express it in the moment. So I always want to say, that's what portals are for. And if you need help in writing a message in your portal, call your providers, have someone work with you on that. So that way you can get out what you need to say, get that stress off of you, and feel a little bit better that you've been able to state some things or questions that you couldn't do in real time, but there's still an opportunity to do it.
Thank you so much to all of you for coming on today to share your stories and experiences. This is a really powerful conversation about your own experiences in this area and research that has been done. So thank you all so much for coming on. Again, today was great talking with you.
Thank you so much. And I just wanted to add one thing. I did want to say thank you so much to Oncology Data Advisor, for providing this space to talk, because it's so important as a breast cancer and just cancer patient survivor and caregiver and a professional in this space to be heard. Like that does a lot for my mental health right there, because I feel heard today and supported. So I thank all of you for, giving that to me and our listeners.
Thank you. Thank you for your courage to share so willingly. Thank you.
Thanks so much.
Thanks, everyone.